Udah. Izin Bu Tuti, kita bisa mulai.
Ya, siap, siap.
Ya, bisa mulai.
Okay, Bismillahirrahmanirrahim. Good afternoon, everyone. A very warm welcome to all participants joining us today, both here in our venue and those connecting with us virtually from another side of the world.
Assalamualaikum warahmatullahi wabarakatuh, and greetings to all of the participants. My name is April, and I'm here with my partner,
Kansa,
and we are honored to be your master of ceremony for today's remarkable event.
we are proud to present the Open Hybrid International Lecture Series, Spectrum, or Supportive, Palliative, and End-of-Life Care Transformation Forum.
This event is proudly organized by the Faculty of Nursing, Universitas Padjadjaran, and we are thrilled to have such an esteemed gathering of healthcare professionals, educators, students, and also advocates for palliative care excellence.
Before we proceed, we kindly ask all participants to ensure your mobile devices are on silent mode, and for our online participant to use the virtual background that we've already shared before. And please feel free to use the chat features for any questions, and we will address them during our question and answer session later.
So, without any further ado, let us begin this meaningful journey together.
To officially open this important forum, we are honored to invite the head of the Nursing Study Program, Faculty of Nursing, Universitas Padjadjaran, Ms. Tuti Pahria, SKP MKes PhD, to deliver the opening remarks.
So, ladies and gentlemen, please join us in giving a warm welcome to Ms. Tuti Pahria. Ms. Tuti Pahria, time is yours.
Ya, thank you, Kansa and friends. Kansa and friends. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good afternoon, everyone, college, distinguished guests, students, and all participants. How are you guys, my lovely student?
We are fine, we're great, thank you.
Yeah, thank you. It is a great pleasure to welcome you all today. Open Hybrid International Lecture Series with very important themes, nursing symptom management in palliative care and of life care. This session brings together professionals, scholars, and students dedicated to advancing excellence in nursing practice and research. Personally, I would like to thank each of you for taking the time to join us for this important and meaningful session. As we know, palliative care and end-of-life care represent some of the most compassionate and complex aspects of nursing practice. Managing symptoms effectively during this delicate phase not only relieves suffering, but also enhances the dignity and quality of life for patients and their families. Nurses play a central role in assessing, managing, and communicating about symptoms, ensuring that patients and their families receive care that is about competent and compassionate. Palliative care and end-of-life care require a holistic approach that integrates clinical expertise, ethical sensitivity, and compassionate presence. That's why effective symptom management stands at the core of this practice, ensuring that patients experience comfort, dignity, and quality of life in their final stages. Throughout today's session, we aim to deepen our understanding of how evidence-based nursing intervention can alleviate suffering, enhance the communication with patients and families, and strengthen the overall quality of life on and off life care. We are privileged to have us our speaker, Dr. Seckin from Birmingham University, United Kingdom, a highly respected figure in the field of palliative care. Dr. Seckin, extensive clinical and academic experience has significantly contributed to the advancement of nursing practices in symptom management. So hopefully all participants enjoy this session for this afternoon. Once again, I extend my sincere appreciation to all of you for your participation and commitment to advancing the nursing care. Terima kasih, thank you. Assalamualaikum warahmatullahi wabarakatuh. Kansa, it's done.
Okay, thank you. Our sincere thanks to Ms. Tuti Paria for those meaningful remarks.
Your words have set the perfect tone and a warm welcome for today's discussion. Thank you.
Okay, so every great discussion need an exceptional moderator, and today we are fortunate to have someone who embodies excellence in palliative care education and practice.
That's right, Kansa. So allow me to introduce our distinguished moderator for today's session. Yeah. So our moderator for today's session is Ms. Chandra Isabella Stenido Purba, a respected lecturer at the Faculty of Nursing, Universitas Padjadjaran, under the Department of Medical Surgical Nursing. So, Ms. Chandra is currently pursuing her PhD in nursing at the University of Glasgow, United Kingdom. And her research is focused on palliative care for cancer patients in research-limited settings. She also graduated at University of Indonesia and also University Padjadjaran. Her scholarly interests can center on focus in palliative care, also oncology nursing, and holistic approach to patient and family care. So here's our exceptional background of our moderator for today.
So without any further ado, let's welcome Ms. Chandra Isabella.
Thank you, Kansa. So good afternoon, everybody. Yeah, we are very happy. Today we have a lecturer from international, and I will like to introduce our speaker. We could see her CV, bright TV. So we could call her Mrs. Muzeyyen. Yeah. So Dr. Muzeyyen is studied in Turkey. So Muzeyyen is the original from Turkey. And she also shared the same office with me for around the last 3 years in University of Glasgow. And she has a lot of research and publication in symptoms management, particularly for people with chronic illness. And she is also, can you guess, she's very young actually, yeah? Almost the same as young as you. So I hope this will make you have a high dream that you also could pursue your PhD in the very young age, yeah? So secretly she is less than Okay, so she's very young, yeah, and but she has a lot of experience in palliative care. And Muzi, we welcome you. You could also find her publication in public palliative care and symptoms management. She also share it in Google Scholar and another kind of publication, yeah. And Muzi, time is yours. Hi Muzi, how are you?
Fine, thank you. How are you? It's nice to see you again.
Nice to see you too. So you have around 172 students in this class. And another is our colleague also from Universitas Padjadjaran, and they also interested in learning together with you. So you have time around 60 minutes, and then we will have like 30 minutes for question and answer. So time is yours, Muzi.
Let's see if I can fit in the 60 minutes. Okay,
Okay, clap hand for Muzi, yeah.
sorry. Is any chance that can I share my screen? Let me see if I can do this. If someone can help me to share my screen, that will be nice.
Or you could send it to me and then we will help you to share from here.
Let me try. Just,
Yes, we could see it now.
should I will be able to. Yep. I think everybody can see it. If someone can confirm, you can see my slide.
Yes.
Yes.
That's perfect. Thank you very much. Bella introduced me, but I will tell about me a bit more. Who am I? I myself, Dr. Muzeyyen Seckin. Actually, I'm a researcher more than a lecturer in our university. My job is doing research regarding symptom assessment and management in heart failure. Because this is my main purpose, I would like to develop a person-led symptom assessment then that will help us to identify the symptom from diagnosis to the end-of-life care stages to lead us the best self-care management for patients. I'm also interested in specifically palliative end-of-life care and bereavement support research because I'm also a member of our REACH research group, and this research group mainly focusing on the palliative end-of-life care and bereavement support research. And recently we're doing like a research for people living with motor neuron disease, carers for people living with serious illness conditions, and developing inequity tools for people at risk not receiving a best palliative end-of-life care around the world as well. So this is about me, what I'm doing mainly in research. And today we talk about a bit more symptom management, but I will start with the symptom assessment because without identifying the symptom, you cannot manage it in any stages, in any phases of the condition. So we will start with very basic information, how we can do this, what is the symptoms, and how we can identify the symptoms in palliative care, and then how we can manage it based on the guideline based recommendation. That is all today we discuss. You have already this brief information from today, but I will just cover again. Palliative care is an approach that improves the quality of life. Patients and their families who are facing problems associated with life-threatening illness prevents and relieves suffering through the early identification, a correct assessment and treatment of pain and other problems whether physical, psychosocial, or spiritual. This is the description of World Health Organization. So what makes the number one job in palliative care is relief of symptoms. That is our number one job. Possibly you already know this figure, but this figure giving the main health condition recurring in palliative care. You can see we have cancer is the top 42.5% people diagnosed cancer receiving palliative care services across the world. But we also have non-cancer conditions receiving the people receiving palliative care. Especially after 2019, you can see the more interest is like going this way, because we're also knowing that like people living with heart failure, people living with COPD, they need the palliative end of life care at their last stage, last phase of the condition. So we also providing palliative care or end of life care services for non-cancer groups. I will roughly say, I think after 2019, it's getting an interest in developing palliative care, or how we can integrate the palliative care in usual like heart failure management strategies, research projects. You can see many countries now focusing on how we can integrating the palliative care, end of life care in the other non-cancer related conditions. So I'm saying this, so you should focus on the symptom assessment. We're not only doing cancer, as a more, you should think about the individual symptom assessment rather than focusing on the one condition-based symptom assessment and management in palliative end of life care. When you learn it, you need to identify the individual symptoms, then the management, then the manage or the provide the symptom control. Based on what individual experiences rather than what the condition. Of course, the condition itself is very important because it's leading us to what is the underlying causes for that symptoms, but you need to focus on first individual symptom assessment and management. I give very quick what we learned today. We learn basically try to understand symptoms and assessment principles, apply the assessment tool effectively, what the kind of tools we're using in palliative care to identify these symptoms. There is a very long list, but I will give a couple of them to you, we're using usually internationally, and recognize major symptoms and the management in palliative care. So I will start with the symptoms. What is the symptom actually? You will see the many description of symptoms starting with it's the subjective indicators of a condition and disease. It's a subjective experience of the patient. So that makes the patient knows their symptoms better than anyone. And primarily recognize these symptoms usually by patients. In some incidents by family members or caregivers. When I interviewing one of our patients, I asked to him, do you have any symptom changes recently? Can you see any changes in your symptoms? Any of them? Doesn't matter, is it physical, psychosocial? And then he told me, actually not, but then he mentioned his 10-year-old daughter say to him, his shortness of breath getting worse when he started doing something. So in some cases, you should ask what they're thinking. You should also considering the family caregivers in their symptom assessment and management strategies. And the other things related to symptoms, the symptom is heterogeneous for each individual. We're not expecting to see the same symptoms for all the patients regarding the same condition, same factors. The symptom experiences will be various. Intensity pattern between individuals will be various. Like when one patient, when you ask them in the morning, do you have any symptoms? It says no. But after 2-3 hours later, when you ask again, it will say yes. I have, like, for example, shortness of breath now, I have pain now. So symptom is fluctuating even a day, in a week, within 10 days. So every time you need to make sure the right monitoring for symptoms. So we're not doing one assessment. We're reassessing every time, monitoring if what is the symptom changing, it's getting worse, it's getting better. This is our job as a nurse as well. And symptom usually used for diagnosis in some conditions, identifying disease trajectories, classifying this severity of disease. In the palliative care is also deciding which palliative care phase of regarding symptom assessment as well, and the deterioration of the disease. I think this quote is explained very well what is a symptom. So, the appearance of symptom usually involves the verbal articulation of the patient's subjective experience of the symptom. As I said, the patient is the best person knows what they experiencing. And then the possibly bodily manifestation that accompanies it. So that's mean that, yes, it's a subjective experiences, but still you can have also objective signs of the symptoms. So you can still objectively assess if the patient having symptoms or not in clinics or in home-based setting. What is really important to assessing symptom effectively? Because when you do it effectively, you will improve the patient quality of life. Please keep in your mind, you already learned this one. Our job is the holistic care. So we're not doing only physical. We need also considering the emotional, psychosocial needs of the people in palliative care or end-of-life care stages. This helps them allow an individual to experience comfort and dignity through their care. So it's really important having effective symptom assessment and management in palliative care. Integrating holistic care principle ensures that all aspects of patient well-being are considered. So this is really important to providing them as like supportive environment to improve their overall satisfaction with their care. And also patient-centered care. As I said at the beginning, you should do the individual symptom assessment and management rather than only focusing on the condition in palliative care. Because later we will discuss the people now living with more than one condition. So it's a multimorbid condition. So you need to more focus on individual symptom experiences, then we can provide the person-centered care. So in these stages, you need to prioritizing patient perspective and preferences during symptom assessment. You need to ask them what they experience and what they need. They will tell you. This leading us to providing best effective management strategies based on their values and their preferences. And this also helps them to feel more participation in their care. And effective symptom assessment is really crucial, is important, providing the best quality palliative care. As I said, you can use the subjective. We will discuss this again later, what it means I say the subjective and objective symptom assessment. This, we will use some kind of standard assessment tools, validated assessment tools. We have already in palliative care. If I remember correctly, we have almost 17 or 18 different validated assessment tools that we can use for patient-reported outcomes and the patient experience outcomes in palliative care. And again, nurses play an important role in early identification and providing the best interventions for symptoms, ensuring optimal patient comfort through the effective monitoring. As I said, we're not doing one-time assessment of symptoms, and education to patient what they can do when they experience these symptoms still, and the collaborative care strategies. You need to think, because we are a member of the healthcare team, we work in collaborative with other teams, and you work in collaborative with the patient carers. So you need to have also the good communication skills in symptom assessment and the management. Okay, as I said at the early beginning, my expertise is actually symptom identification in heart failure. This is one of our recent publications, and as you can see, the symptoms are always there. It's starting pre-diagnosis, and still on diagnosis, we can have the symptoms. It's usually we call them the typical symptoms of heart failure, but in some cases now we know that some people doesn't have the typical symptoms of heart failure when they get diagnosis. So it's a bit changing now, but in all research, we usually using the typical symptom of heart failure, like shortness of breath, ankle swelling, and fatigue. For example, these three top symptoms, still be counting them as a typical heart failure symptom during the diagnosis. And we have also seeing a symptom after the diagnosis stages, especially when we come to the advanced stage of heart failure. So usually we're counting as well the palliative care stage here, and then of life care, you will see the severe symptom experiences. It's not only one symptom, it's multiple symptoms many times, and then a significant limitation in their life. Many patients totally dependent of their carers, their family members. They cannot do even their daily task when they reach the advanced stages and then the end of life care. As I said beginning, the symptoms, we're taking into consideration the symptoms from diagnosis to end of life care stages in heart failure. But I think this table is showing at the diagnosis stage, early stage, you can see a couple of symptoms we can identify throughout research. But when we come to the advanced stages, as I said before, you will see the many different symptom experiences. And this symptom experience is not the same for all patients. In our research, we find that the people experience a symptom between 3 to 17. So some people will have 3 symptoms. That's maybe the typical symptoms of heart failure, but some people has more than 16, like 17 different symptoms, this providing us like multiple symptom experiences. And what is the main reason in heart failure they're experiencing more than one symptom actually? Because as I say, the multimorbid or comorbid conditions. When you come to the patient, some patients will have more than 2 chronic conditions, for example, or cancer plus another condition. So every time you need to think with the multimorbidity or other comorbid condition, people tend to experience more symptom experiences. You will see the multiple different symptom experiences. It won't be the same. It will be the very heterogeneous symptom profile between individuals. And also the other reason is the advanced stage and frailty. This is also another reason that people experiencing different symptoms than their condition, attributed to their condition. In some cases, older individuals, for example, saying that I have this symptom like the fatigue, but they're thinking that this is related to their age, not their condition. But still, this is a symptom they're experiencing, and you need to manage this symptom without looking is a condition related or non-condition related. You still think about identifying the right symptoms, and the most important one, the one needs urgent controlling, and then you need to provide the best management strategies for them. Let's go back to the symptom in patient with serious illness. This is the one of the recent studies. If you can see that this study is including actually for over 44,000 people. It's mainly people living with cancer, but they're also counting the other condition and looking the proportion with severe symptoms or problem according to diagnostic group. As you can see that in this line, some of the symptoms higher in different groups. Like if you're looking for the fatigue, it's higher in cardiovascular disease group rather than, for example, let's say it's a cancer. But if you're seeing the pain, it's higher in other non-malignant disease. So that's mean that the symptom also will be the different main experiences based on your diagnosis, based on the patient's other factors, like let's say it's the age, maybe sex, because sometimes there is the cultural differences in symptom experiences, and then it will lead us to different symptom assessment and the management strategies as well. So please keep in your mind this figure, because most of you talk about the symptoms rather than the others, but I will also explain why it's really important to understand the full spectrum of symptoms in palliative care. So you can see that this is actually the most common symptoms in palliative care, and then we have the fatigue, appetite loss, pain, dyspnea, insomnia, constipation, nausea, and vomiting. There also the quality life, emotional functioning problem, and the physical functioning problem here. The question, how to assess symptoms. As I said earlier, we can have subjective and objective symptom assessment. When we say the subjective symptom assessment, actually we're mentioning when we say the subjective symptom assessment, actually we mentioning patient-rated or self-reported. So basically you're asking the patient to describe their symptoms, to tell you what they're experiencing in their life, condition or non-condition related. This is the best practice for symptom assessment, because we say this is subjective experiences of the people. And this is also improve patient participation in their care. So giving them the encouragement and motivation to focus on what they can do is also really important, having their opinion in their care decisions. And the other one is the objective, I would say. This is the proxy reporting. When I say the proxy reporting, you need to think about someone who can answer question about symptom experiences from the patient perspective. We're not asking the patient. It can be the carer, the family member, or the clinician, or like nurse, someone in healthcare setting. So they can also answer the symptom assessment tools behalf of the patient. But as I said, this is only used when the patient is unable to raise symptom distress-threatening experiences. It could be the cognitive impairment related issues and the patient cannot answer, or the other medical issues. Then you should thinking about asking a carer as the first stage if it's possible, because they will be a bit patient 24 hours, and then we can get the best symptom assessment. If not, still you can use a clinician rate score. For the clinician rate score, we using our observations and the clinical judgment. When we discuss the tools, we're also seeing the different type of tools we have, because when I say it is a patient rated, that means that that tools definitely completed by a patient. But when we say the clinician or proxy rated, also carer, family member, or the clinician can use that tool to identify the symptoms of the patient. So please keep this in your mind, because somehow in the clinics, we usually use the clinician rated score, but it's the best if we can use some things that the patient and the family members provide us to their symptom assessment and experiences. It's not really like for palliative care, actually. It's more than a symptom. It's a problem identification. So you need to be have their opinion regarding their symptom assessment, regarding their problems. It could be financial, to identify how we can provide the best care, how we can help them in the best way. Not only be trying here, it's the physical relieving. We also need to think about the psychosocial problems for patient and families as well. Now is the time for the symptom assessment tools. As I said, I think the last study is showing that we're almost using 17 different patient-reported outcomes and experience outcomes in palliative care settings. So this is very long because the sum of these tools is very generic. We're looking many symptoms in these tools, but we have also like one's pain-specific, like brief pain inventory, or the depression and anxiety specific tools we can use in hospital to identify the patient symptom experiences as well. So as I said, this is the list that possibly I will talk a couple of them, but I'm not going how we scoring them. I will just provide the detail, what kind of symptom they included and how we're doing it. And this tool usually could be used in research and the clinics as well. But I specifically mentioning one is really important, is the Integrated Palliative Care Outcome Scale, IPOS, is now internationally widely used one. Many countries use this Integrated Palliative Care Outcome Scale. So I will talk about what kind of problems is including and what kind of palliative care outcome we will have later. So symptom assessment scale, SAS, and it's a patient-rated, so it means a self-reported. You need to ask the patient to complete this scale, basically. It's including 7 items, and these are the most common symptoms, but there's also a chance that you can add other symptoms because it's an open-ended question section if they need to report other symptoms as well. So what kind of symptom we looking in this tool scale? These are difficulty sleeping, appetite problems, breathing problems, nausea, bowel problems, pain, fatigue. And then I said there is another open-ended question if they want to report other symptom experiences. So you can see it's only 7 plus with other symptoms. And what we have, another one, POS, a palliative care outcome scale. This is also widely used, but now we have integrated IPOS, and it's the updated version of this. So that one is the most used, but in some cases still some places use this one. So the reason why I included this is a patient-rated and proxy reporting. So this tool have 3 different versions. One version for patient, one version is for family, and the one version for clinician. So you can assess the symptom based on the patient-rated, clinician-rated, or carer-rated version. So it will be possible, and it's help us identify the palliative care outcomes and evaluates the overall patient and family outcomes in palliative care. What kind of symptoms there actually? Assess pain, other symptoms, other physical symptoms actually, anxiety, family anxiety, information, and other practical problems in this tool as well. You will see this one is very commonly we use also this in research, almost for everything. We're using this one is in heart failure research even. It's a patient-rated self-reported tool, measure the severity of common symptoms. As I say, it's like when you think about the common symptom, the first thing is a pain, a tightness of fatigue, drowsiness, nausea, and appetite, shortness of breath, depression, anxiety, and well-being. So mostly the physical symptoms with the depression and anxiety, along with the depression and anxiety here. And this is also used for symptom monitoring because you can repeat it easily if the patient conditions allow us to do. And as this is the now internationally recognized and widely used one, integrated palliative care outcome scale IPOS. It's also patient-rated and proxy reporting tools. So we have, again, 3 versions of these tools. The patient can use family members and the clinician-rated version that we will have to use in practice. This is, as I said before, an update, a more comprehensive version of the palliative care outcome scale. And now it's used internationally. You will see in many palliative care research or clinics that start using IPOS. And is assessing physical symptoms, is including pain, weakness, breathlessness, nausea, etc. So it's the same list with the others. And also looking for the psychological and spiritual issues, communication and practical concern, family anxiety and information needs. So now we every time discussing the symptom, but here we have the communication and the practical concern, because that's really important to have an effective assessment and management regarding symptoms that the people experiences in palliative care. And this is a clinician-rated measure. The reason why I added actually this one, because it's recently used, commonly used, I think, in clinics to decide it, palliative care phase is like if it's urgent, it's not. We also different tools is coming, but they are all the main research, piloting research, I will say. They still trying to understand is acceptable or not, like the run PC, that it could be used to identify the palliative care phase based on the symptom or emotional issues. But this tools is, as I said, is a clinician-rated measure. It's a holistic tool for initial screening and ongoing coordination of care in palliative care. So facilitate the global assessment of 4 care domains, as I said, pain, other physical symptoms, psychological and spiritual issues, and family and caregiver carer related concern as well. This helps us to identify overall prioritize of care, review the effectiveness of the care plan. So as I said before, we're not doing one-time assessment and management. We're doing assessment, providing the interventions or our management strategies, and then reassessing to make sure that what we provided to them, it's actually work and the symptom going under control. If not, then you're going back to the beginning, assessing again, to make sure that what was missing and how we can help them to manage their symptoms or control their symptoms more effectively than the beginning. So this is also helping us to review the effectiveness of the care plan in palliative care. Effective communication. Actually, this is the main one of the main domains in palliative care. The reason why I wanted to include this one, because without effective communication with patient, family member, you cannot identify or manage anything. So you need to have a really effective communication skill. So when we say the effective communication, but this is regarding symptoms, is not, I'm talking about how we can have the effective communication in palliative care. This section is about more how we can have effective communication regarding symptom assessment. So you need to make sure that symptom is a subjective experiences. So you need to keep in your mind subjectivity. So don't say the patient in some cases, because patients say in pain, but you cannot see the bodily manifestation or any physical appearance, and then maybe in some cases you can ignore it because you're thinking that the patient doesn't have pain, but then they say the pain, they have pain. So you're not saying no, even if you see the objective signs of the pain or not. If the patient say they have pain, you need to take into considerations and try to understand what is the underlying cause of that pain, what kind of pain is it, and how we can help them to reduce this pain. So keep in your mind, subjectivity is the first domain. So every time encouraging your patient to share their personal experiences of symptoms, you need to ask them. This is really important. We are not guessing, we're asking. We're not asking them like a tick box exercise as well. We're not asking, do you have pain or not? No. In some cases, asking an open-ended question is most important than asking, do you have shortness of breath? Do you have a pain or other specific symptoms? To ask them what they're experiencing, what is the problem that they're facing recently, what they change in a couple of days in their health conditions. To specifically ask what they are experiencing rather than the ignoring their experiencing. So you need to include them in their assessment and management. That is the first things in effective symptom management. So this helps us to tailor care approach effectively. If you want to make sure that the symptom management interventions or the strategies will work, you need to include them. So at this level, encouraging patients, their caregivers as well, as a bonus, I will say, in their care, to talk about their experiences, talk about what they want, what their preference is really important. And the cultural sensitivity. I think this is hot topics we will hear everywhere, but it's also really important in symptom experiences because we know that in some how cultural backgrounds affect the symptom assessment and management. In some cases, they will have culture-based different complementary therapies they prefer to reduce their symptoms or to control their symptoms. Apart from that, we're thinking that will work. So still, you need to understand the cultural background to approach symptom discussion with respect and empathy without judging. That is also really important. Because in somehow, I had a patient and we were discussing the shortness of breath management. And then he said something to me, I have never heard it. I don't think so it's working. And then I say, do you think that this is work? And he said, yeah, it's working. It was a kind of herbs that I've never heard in my life, but it says it's working on shortness of breath. And he was using it. And as much as the patient subjectively thinking it's working, I feel good about it, I think there's a kind of affirmation possibly, but we didn't judge. And we said, okay, if you're thinking that it works, we can't see any harm to use it for shortness of breath, and the patient was using it. So without judging, you need to listen, you need to understand their cultural backgrounds or the customs, how they helping them to manage their symptoms as well. And assessing cognitive abilities, as I said at the beginning, the cognitive issues is a slightly problem for us in symptom assessment because we cannot ask the patient directly to assess their symptom or tell us what they're experiencing. So you need to definitely assessing the cognitive abilities of the patients to accurately gather symptom information. If the patient doesn't have that cognitive abilities, they not provide you or lead you to right symptom assessment, and then you cannot have the best symptom management for the patient. So if you want to do best symptom assessment or management for your patient, you need to assess the cognitive abilities. Then you can provide the optimal management strategy, optimal management for them. And the common symptom management, as I said, we devise a symptom as a subjective experiences, but still we can have the subjective and objective symptom assessment. We have the different version, but still we can use it. And then we discuss the validated symptom assessment tools that we widely use in palliative care. As I say, it's a very long list. I gave you just a couple of them. I was thinking that could be the best if you know or aware of to use in clinics or in research, because how we deciding the best practice, we deciding is coming from the best research and best education. So you need to be able to use them in your research and education as well. And then now we will discuss the common symptom management in palliative care. As I said, if you remember the first figure that we're discussing, there was a couple of seven symptoms that we usually commonly looking in palliative care. But I choose a couple of the different symptoms as well here. Maybe it's really important. But please keep in your mind, this is very basic information about these symptoms and the symptom management. It could be very different for each individual, as I said, because what is the underlying cause? If it is different, then you need to think about the different symptom management strategies. So you need to make sure to understand what is the symptom experiences and what the underlying cause of these symptoms experiences, then you can manage it based on, of course, patient values and preferences and the needs. We will start with the pain. That is the top one. As I said, every time when we're discussing the palliative end of life care, as a pain, it will come first. The pain can be categorized into nociceptive, neuropathic, and the combined types, each requiring the distinct assessment and management strategies to optimize patient comfort and well-being. So this different type of pain management actually guidelines giving a different pathway to how you manage it, like the pharmacological management strategies based perspective, of course. And what kind of assessment tools that you can use in clinics or in practice to understand the pain experiences of patients? You can use the numeric scale. It's a very straightforward method for pain intensity measure, scoring 0 to 10. You're asking basically the patient, can you tell us your pain score, like 0, none, no pain, till to 10 is a very severe unbearable pain, and then you're having this scoring for pain. You can also use the visual analog simple line representation for subjective pain assessment. It's actually the same scoring system, sometimes 0 to 10. So you're showing a visual, like the paper base or sometimes, or the screen, to asking the patient, they thinking that their pain fit in the visual analog, and then you will have roughly an idea what is the severity of the pain. And then you can also patient descriptive charts we have in the clinics usually. This is the descriptive terms help and articulate the pain experience effectively, like what kind of pain you have. Is it dull pain? Is it very sharp? Or is like a fluctuation over the period? And it's like increasing with the movement, or what's helping trigger your pain question in this chart usually. So it could be the difference based on the clinics, because there are a couple of different versions of this. It depends which one you're using. But when you use the scales, you will have the roughly pain severity and what kind of the pain actually they're experiencing. And come to the pain management. And when we're discussing any symptom management, please keep in your mind, every time we will have non-pharmacological and pharmacological. I included pharmacological management because I'm believing that as a nurse, we working in a healthcare team. So we are the part of healthcare team. And in some cases, we should know that this pharmacological management strategies as well, to say, if you're thinking that, for example, non-opioid analgesic is not help your patient, that is the first option to give. But still, you can have a discussion with physician to thinking about the opioids, maybe. But for this, you need to know what they are, what their guidelines saying for them. And that is the reason why in this presentation, we will also discuss the pharmacological management, but I'm not going very detailed for each one, but like what kind of for example, non-opioid analgesic we can provide for pain management. But you need to keep in your mind that we have every time couple of options, is including pharmacological and non-pharmacological treatment methods to control a symptom. For pain, we will have the physical, non-pharmacological treatment methods, positioning, massage, aromatherapy. Actually, this is the research was saying. The research saying you could use this to reduce the pain. But as I said, some cases we can't see this is 100% will work for our patient. So sometimes we need to try to alternative. We try one method, it's not working, you try the other methods. So it's good to know at least a couple of different non-pharmacological methods when you treat the pain. So for example, you keep in your mind as a physical, you can help them the positioning. If it's the pain, is it some places that you can massage like the head, you can do it, but again, there is like specific courses for them, how you can do it. Please don't do anything that you don't know what you're doing for their symptom management, because our main goal is reducing the symptom, not triggering the symptoms. So keep in your mind, but positioning, everybody can do it. If they have any issues, any pain, for example, if they're saying that when I lie down my right side, I'm feeling pain, you can have the different positioning or the best positioning that the patient can relieve their symptom. And the cognitive modalities, we call it the relaxation, deep breathing and mindfulness. Deep breathing exercises usually works in some cases, so I strongly suggest you use that one and help them to relax. This is also really helping to reduce the pain experiencing. And the pharmacologic management, if it's the pain mild to moderate, you can start with the non-opioid analgesics. But if it is moderate to severe pain, guidelines say start with the opioids. Opioids is the strongest version of the non-opioid analgesic like the morphine that we could use in usually the cancer cancer-related pain management. But as I said, the monitoring is the key. You assess the patient, you identify they're experiencing pain, and you provide the pharmacological or non-pharmacological, especially if the patient having a pharmacological management, especially for opioids management. You need to also monitor the side effects. That is really important. And the effectiveness of the management strategies to please make sure that what you provided, what you suggested them, what you giving them, it's working. And then this will help us the patient and improving the patient comfort and providing a supportive environment during this palliative or end-of-life care phase. And this is about the pain, and we're passing. So this is my favorite one. That is the one I think it's really distressing symptoms. You will hear this from many patients. When they have breathlessness, they will definitely tell you that it is really distressing symptoms. They feel very stressed when they have breathlessness because they start thinking they're gonna die because they cannot breathe, suffocating from breathing. They cannot have enough air in their lungs, and then they start thinking, okay, they're dying. You will see the many patients call ambulance when they start feeling breathlessness, especially severe breathlessness. Lead them to do admitted emergency because they cannot cope with. So keep in your mind, in some cases, the patient when start the other symptom like pain, fatigue, they never think about that they're not going to die quickly. But breathlessness experience is a bit different. They start the breathlessness experiences, they start thinking this is an experiences, and just let them to die. Because many heart failure patients told me that when start the breathlessness, the first things in their mind, their heart stop. And this will be the end of life, end of their life. So this is really important symptom experiences for them, and you need to definitely control the breathlessness as much as or as soon as possible that you can. Breathlessness or dyspnea, you can see usually they're using alternate each other, but there's a slight differences between, but it's not that important. So we keep saying breathlessness and dyspnea is as I said, is a very distressing symptom experience by many patients in palliative care in heart failure. And it's may arise from various causes. As I said, it could be lung disease, it could be heart failure or anxiety. In some cases, when people feel anxiety, they cannot cope also, it's coming with breathlessness as well. An effective assessment of dyspnea is really important, including patient self-reporting. Patient will tell you they're feeling shortness of breath or breathlessness, and observing respiratory patterns. You will see the very short, sharp breathing, because they cannot have the enough air in their lungs, so it's affecting the very short and quick breathing sessions for patients. And using validator to capture the severity and triggers breathing accurately. But they could be different based on the condition. Observation is the key to accurately assessing the breathlessness. As I said, you can still observe the patient, so you can hold also your objective symptom assessment for breathlessness experiencing of patient. How we manage it? As I said, we have the different option again here. Non-pharmacological or pharmacological. For pharmacological intervention or treatments includes opioids, oxygen if hypoxia. Without hypoxia, the research showing that oxygen isn't working. So if the patient is hypoxic, then you can provide oxygen. And the benzodiazepines. This could use like opioids, very small dose, and the benzodiazepines we're using for treating the breathlessness. But research evidence, especially like a Cochrane review and other systematic review, showing that they're not strongly helping us reduce the breathlessness in clinics. But still, we have them, and we're using very small doses, as I said, not the full, not like treating the pain, but we still can include them in their breathlessness management as a pharmacological treatment option. But non-pharmacological treatment should be considered in the positioning and breathing techniques again. This is really important, because in some cases, patients feel more comfortable and having a regular breathing when they sit down or different positions. So you need to make sure how they can have how they can breathe comfortably. So you need to give the positioning and the breathing techniques. And in some cases, if they're really struggling, you can try to make them calm and then try to mobility aids, and sometimes it's muscle stretching. But as I said, if it's the patient can do it. If not, don't force them to do it anything. So, but you can try the positioning and breathing techniques. And other things what I didn't include here, but the fresh air. In some cases, many patients saying when they start feeling breathlessness, they're opening the window, they're having a fresh air, and then they start thinking it's helped them to reduce their breathlessness experiences. As the oxygen level will be the same, but I think the cooling air helping them to get calm and then improve their breathlessness experiences. So if something happen, you can help them to getting fresh air. You can open the window in the hospital. So this will help them to improve their breathlessness experiences as well. But as I said, breathlessness can cause based on the different conditions. So you need to also understand what is the main reason that they're having breathlessness. If it's, for example, anxiety, you need to make sure that they're getting relaxed, and reassurance is most important than others as well. And the breathlessness also, we're not usually talking about here, it's a family support, but you need to also make sure if there's any family members there, because it's very scary, I think, situation to them to see their close one in that position. You need to make sure that they also have enough family, enough support. And the other one is fatigue. I think this fatigue is a bit different symptom experiences, because we will discuss with many condition, like if a patient diagnosed with diabetes, we discuss fatigue. If it's a cancer, we discuss fatigue. If it's a heart failure, we discuss fatigue. Every time fatigue is coming in somehow as a symptom experiences of patient. And as I said, it's a common symptoms also in palliative care, if you remember the first table. And patient describe a persistent lack of energy and motivation. They will tell you they can't do anything because they don't have the energy to do anything. They're really tired all the time. They're waking up and they say, I'm tired already. Not resting, you're sleeping like 10 hours, but your patient saying, yeah, I slept 10 hours, but it doesn't work. I'm really tired. I don't have any energy to do anything. They don't want to go out, even a bed. So and this is impact the patient quality of life, and also affecting their daily activities, enjoy the time, because if you don't have any energy and motivation, you won't be happy to do anything. And as I said, when they start feeling fatigue, they have a couple of issues like doing their daily activities, and it's reducing their quality of life. It's also is also increasing some of the emotional and psychological distress because they start feeling more depressed, for example. So this is really important symptom experiencing that we need to provide management as well. And fatigue management is a bit different. You still can use some of the pharmacological, but in research, I didn't see the very strong evidence that you need to use the pharmacological treatment. So that's the reason why I just included motivation and exercise. You need to motivate the patients, encourage them to do at least the basic daily task that they can do if it's possible, if the patient has an ability to mobility abilities, then we will try to motivate them to do joy in their life, and at least reducing the overwhelming of fatigues from psychological point of view. And also you can provide this exercise, but when you're doing it, you need to make sure that it's active planning, actively planning, and involves like short intervals of rest between tasks, like one things, and then have the patient rest, but still helping them to feel motivated and being a part of their life. So this will help maybe increasing their quality of life and providing their independency and feeling more emotionally well. And nausea and vomiting, that is the other one we see commonly in palliative care. And as I said, some of the symptoms can come from various factors. That nausea is one of them, and it comes like medication side effects, metabolic imbalance, or disease progression. And it's really effective assessment is really important to understand what is the reason they're having these symptoms, and what is the trigger or severity patterns of this symptom. If you identify this, then we can use the more non-pharmacological treatments to help them to reduce this experiencing. But if it's poorly controlled, like in other symptoms every time, if we're not controlling one symptom, it will become more problematic, because one symptom definitely interact with another symptoms, and then we will have more symptom experiences at the end of the day. So if the nausea or vomiting poorly controlled, it will be associated more physical, cognitive, psychological distress for patient. And then at the end of the day, the patients and the family start to feeling more fears of death from dehydration or starvation. And what is in the management strategies? As I said, we have the pharmacological antiemetics. You can use this to relieve the nausea, but also non-pharmacological. If you observe, if you're seeing that any reasons trigger, any dietary reason that trigger this nausea or vomiting, then you can make an adjustment. So observation is really important, and non-pharmacologically, I think the best one, dietary adjustment and hydration. You need to make sure that the patient having enough fluids, and psychological services sometimes, some cases, is really helpful. And one couple of research showing that acupuncture also support overall symptom management. It could be used, but as I said at the beginning, somehow in research we cannot see this strong evidence. The nausea and vomiting, one of them, we cannot very strong evidence to use this pharmacological and non-pharmacological treatment in nausea and vomiting management.
Muzi, you have 2 minutes left.
Okay, this is the last slide, let's say, last two slides. And this is the delirium. I added this on purpose because I think this is really important by not giving you full detail. Actually, it's very long list in the guidelines, and I do strongly suggest that you should read them. Delirium is characterized by acute change in mental studies, often fluctuation and impact on attention or cognition in patients. In some cases, we have this, and it's really scary for patients and patient family members. So common cause of delirium can include the infection, as I say, the metabolic imbalances like nausea and vomiting, and the underlying chronic condition that affect the brain function. We have the various screening tool to identify what is the delirium stages and how we to help us to how we can help to reduce it. As management strategies, it's very long list, but I start with the environmental modification. You need to make sure the patient is safe, calm, relaxed. So you need to reassurance the patient and family members. And medication as well. You could use haloperidol if needed, if other management strategy is not working. And as I said, it's like very scary experiences for both patient and family. So you need to make sure that support the family and caregivers as well for this condition. What is the key takeaways from this? We discussed the subjectivity of the symptom experience, and then we say the identification is really important to for effective management. So use the validated assessment tool. You could use what is already in your country. I don't know. Maybe you have the other validated tools that you can use to identifying the full spectrum of symptoms or each individual symptom severity and distress for patient. So use of the validated assessment tools, and make sure that it's a self-reported or patient-rated tools if you can do it. If not, we also have other validated assessment tools options like clinician-rated or carer-rated that you could be used. And holistic assessments, please keep in your mind, as I said, we're not only focusing on the physical, psychological, and social and spiritual dimension of assessment is really important. In my presentation, I didn't include the depression, but it's also one of the most common symptom experiences in palliative end-of-life care. So make sure that you're also including them as well. Communication with patient and families about symptoms is really important. Identification and management of symptoms. Please keep in your mind that communication is the key. And as a nurse, what our responsibility is observe and monitor symptoms to identify early sign and deteriorations or distress. Please keep in your mind, we're assessing one time, providing management strategy, and reassessing again and again until make sure that we control the symptoms. So observing and monitoring symptoms, they are our first job. Providing education about symptom and management option, because in some cases, the patient experiences the symptom again and again. So you need to make sure that you're providing right education. So when they have this experience, for example, this experiences, they can get the fresh air, they can try to reassure themselves, etc. So your another job is to make sure that providing right education and training for patient and family members to deal with the symptoms, or in other words, telling you what kind of symptom they experience and any changes in their symptoms. That will be really important to understand their needs and needs effectively in palliative care. And the last one, interdisciplinary collaboration. As I said, we're working as a team, including our healthcare providers or members and our patient and caregivers. It's a collaborative work, so ensure comprehensive care to develop to tailor intervention to meet the holistic needs of patients with your team members, including patient and caregivers. And this is a couple of the guidelines that if you want to look at, I can copy and paste in the chat because there was very long with like 50 pages that I talk very quickly, a couple of symptoms, but there are many symptoms in palliative care that the people experiencing, and you need to understand each one, how we can identify them, how we can manage them. So I strongly suggest you to look at the couple of pain and symptom control guidelines in palliative end-of-life care, please. And thank you for listening.
Wow, big applause for Muzi. Very clear explanation about symptom management. For Muzi, we already have several people that with several questions. Maybe we could read one of them.
Okay, let me get my screen. Yeah.
Yes, from Muhammad Anjas. I don't understand what serious illness is. What diseases are considered serious illness? Thank you.
Sorry.
Yeah, Muhammad Anjas. So Muhammad Anjas, I would like to ask you a question. I don't understand what serious illness is. What diseases are considered serious illness? Thank you. Maybe you could-
Yeah, serious illness actually, our NHA has a description for serious illness, what we kind of condition thinking the serious conditions in palliative care stages, for example. If you go to our website, you will find a list. We're talking about when we say the serious illness, you can think about like any conditions that let us do life-threatening. For example, dementia is a serious illness, especially advanced stages. When they reach the advanced stages, heart failure is a serious ill conditions when they reach the advanced stages. So when you actually basically mentioning the serious illness, be talking about the life-threatening illness, be thinking if they not manage very well that condition, people will die from it. So keep in your mind, actually there is a very long list, so I can't keep remembering all the conditions, but you can check it. It's there is a website when you put it there, serious condition descriptions, if it come up, and then showing you what is the distinct descriptions for each condition that we're counting as a serious illness condition. But basically, you can think it's a life-threatening conditions that's for patients.
Thank you, Muzi. And Muhammad Anjas, are you happy with the answer from Miss Muzi? Amjas sudah puas? Okay. I think we have another question. We have another question in the chat box. Okay, so we will open the question from the class, from class A, B, and C, Pangandaran. They have any question, you could ask Miss Muzi directly. You could ask in Indonesia. Yeah. Yeah, okay.
That I can translate.
Yeah. Okay. Come here and say your name and do you want to ask in English?
Thank you. I want to ask about, are there like standardized scales or okay, I want to ask, are there like standardized scales or tools recommended in assessing symptoms in cognitively impaired patients? Because you mentioned about patients' cognitive disabilities being one of the challenges in symptom assessment, but I want to know the explanation on what would nurse do if the patient was already cognitively disabled. Thank you.
Thank you. I agree with that one. And actually discussion in symptom management, it must be based on the open-ended question. It needs to be individual symptom assessment. But in some cases, we can't do this. As you say, if there is any cognitive issues or ability to impairment of patients. The reason why I mention, if that is not happen, we can use the clinician rated or family members rated scales or tools. If you remember that my how to assess slides, we have two different assessments. One is the self-reported patient rated. This could be used only patient is really cognitively well to describe what they experiencing and how we can help them. But if not, then we have second option is a proxy reporting. that still you can use this kind of standardized assessment tools in your practice to make sure that identify the symptom experience of patients. I know it's like not the best practice possibly for symptom assessment, but we need to still identify to provide some things, because what we're doing, not just knowing and ignoring, we're trying to understand what their symptom experience and providing the best care. If there is anything that regarding the cognitive abilities, then that is the reason why we're using still clinician rated or the family members rated symptom assessment tools in palliative care, because that is the second, I think, best option that we can do it. We cannot ignore, we cannot think that the patient doesn't have any symptom experiences, still they are. So that is the reason why, if it's not individual, it's not self-reported, it's not patient-rated scale we can use, then we have to use the proxy reporting that we're counting as a family member rated or clinician rated scoring system for symptom assessment.
Do you get
I don't
the
know if it's happy with the answer.
Okay, so I will try to translate ya. So, if kalau pasiennya tidak sadar, bagaimana kita mengukur kognitifnya, ya? Nah, pasien kan tidak bisa mengukur. Kita bisa memakai proksi. Orang-orang yang mengerti pasien ini, baik caregivernya, keluarganya, perawat atau dokter atau siapapun yang berhubungan dengan pasien, semua informasi itu kita simpan dijawab oleh orang lain yang mengetahui kira-kira seperti itu ya maksudnya. Thank you, Buzi, and thank you, Gero. Do you have another question? Bram, do you want to ask something? Bram? No? How about class A? Class A, do you want to ask any question? Mumpung ada expertnya ya, so before we have the expert in symptoms management and Muzi's research mostly about that, and she already researched almost 500 people in Australia. So she gathered all the symptoms management in Australia and also in UK, so and also in Turkey, yeah. So
We have the research from Turkey looking for the British experiences and management from patient perspective. We have another research from Australia. We're basically looking for the symptom experiences differences based on the different heart failure subtypes regarding left ventricular ejection fractions and the symptom changes over a year to make sure that which point that they're having different symptom experiences, like worsening symptom experiences, that we can provide the timely management. We have also a couple of different reviews and upcoming studies looking for the developing a symptom assessment tools, and then let us to develop individual symptom management metrics.
Jadi lihat ya, ide penelitiannya bisa dengan apakah simptomnya berganti setiap tahun, berubah enggak? Jadi kan mengikuti ya, mana 8 simptom terbesar gitu kan? Kemudian berubah enggak tiap tahun, dipengaruhi suhu apa tidak? Kan ada 4 musim. Kalau musim ini berubah atau tidak, musim itu berubah. Jadi itu bisa jadi ide penelitian ya. Oke. So we also have another participant in the Zoom. Maybe some of you want to ask also. Bay Haki, do you want to ask any question? Pak Bay Haki? Coba dilihat siapa aja. Ya.
Izin Ibu belum bisa mengajukan pertanyaan.
Oke. Mungkin yang lain? Class A and okay, we have another one. How if patient rejected the symptoms management? What should we do? Thank you. So from Kenita, she asked about how if the patient rejected our symptoms management.
They have to write to reject it or accept it. Our job is just providing them what we can do and explain every time the reason why effective communication is the key. They need to trust you. But in some cases, if they don't want to have that management strategies that's providing, they have say no. This is their right as a patient, as a human being, and then you cannot force, but you can try to understand what is the reason they're rejecting, and try to provide an alternative, what you can do. Because as I said, some symptom experience is very distressing, and in many cases they will accept. But if they say no, it could be also possible. You need to record it, because recording and documentation is most important to saying you try as a nurse or as a clinician that you are trying your best to help the patients to control their symptoms. You explain what you need to do based on the management strategy. But if your patient rejects it, you need to document it and saying, and I assess the symptom and the symptom experiences, and we provided a detailed management plan, what needs to be done, but patient rejected. You need to make sure that you documented this, but as a patient, they have a right to reject their treatment options or the symptom management options. You cannot force any patient to take a paracetamol, like forcing you have to do it. No, we're not convincing. Yeah, you can try. You can try to explain why it's really important to control that symptoms, but you cannot force your patients to accept their treatment option. If they say no, definitely no. And you try already convincing, explaining with a really nice communication skills, and the patient say no, then you will accept it and document it. Just make sure that you write it in their care plan, what you provided and what they said.
Iya, jadi Kenita, pasien punya hak untuk menolak ya. Nah, jadi kita harus menulis. Sudah dijelaskan pasien misalnya demam, disarankan minum paracetamol misalnya. Pasien menolak dengan alasan apa? Kita tulis alasannya. Nah, kalau pasien tidak mau, kita tidak usah pundung ya. So, the patient have a right, but the nurse should write down all the reason why the patient rejected the symptoms management. Okay, do you have another question? Okay, another one. Okay, Bu Emi from Palliative Care Association in West Java. How about the treatment for end of life, and does the patient include in the therapy and in decision therapy? And did the patient or did the, I think this is about the nurse already applied the ACP or dignity therapy?
Sorry, I didn't understand the question.
So, I think she wanted you to share how the end of life care in UK. Did the end of life care, the decision to give the end of life care to the patient also include the patient? Did the patient also can decide what kind of symptoms management for them? And did the nurse there already apply the dignity therapy?
We have all options as much as we can do. We have district nurses if they are home, if they're hospitals, we have the physicians that the whole team. And what is working best for them as an advanced care planning, as dignity therapy, they will already including and discussion with family and the patient. If there is any issue that the patient cannot joining their decision-making process during the end-of-life care phases, but still they try to contact family members to make sure that they understand what we're trying to as a care management or symptom management for patients. Is in some cases if they so it's like a process, you know, if because of in the UK we have home-based palliative care or home-based end-of-life care or the hospital-based. So we have two different pathways, so two different interventions going through this home-based or the hospital-based. It's usually people prefer to die in their home if it's possible, and then they can choose what kind of symptom management they want, and in some cases they can reject for end-of-life care. In a hospital, again, they can choose rejecting or accepting, but in that state, we're still trying to make a decision what is the best for patient. And every time dignity therapy, you will see it as including palliative end of life care stages, mostly in the UK. But as much as the it is available for patient condition at that level, but we can use also other kind of advanced care planning methods and management strategies for patients. I don't know, is to fully answer the question.
Yeah. Actually you already answered the question. So Ibu Erni ya, ini saya cerita sedikit Bu Erni ya. Kalau di UK kan itu udah 100 tahun palliative care-nya, jadi sudah established ya. So already 100 years established in UK. So sistem mereka Bu terintegrasi. Jadi ketika pasien sudah di end of life care, diputuskan di rumah sakit, nah pasien bisa milih nih, saya dirawat di rumah, dan nurse akan datang merawat saya sekali 3 hari, sekali 4 hari, atau 2 kali sehari. Lalu akan ada volunteer juga yang langsung link, misalnya membantu mandi, membantu belanja, membantu beresin rumah, masak, dan lain-lain. Termasuk kalau pasien sudah akan meninggal, itu akan link dengan pemakaman yang akan mengurus jenazah. Jadi itulah namanya mereka sudah terintegrasi gitu. Pasien dari bisa milih saya di home base, palliative care atau di rumah sakit. Nah, mau di rumah sakit atau di rumah itu sudah link gitu. Jadi istilahnya catatan BPJS-nya kali ya, kalau di kita itu sudah link kemana-mana gitu. Dan pasien ya di sana memang autonomi amat sangat ya. Jadi pasien harus memutuskan. Kalau kondisinya pasien tidak sadar, tidak bisa memutuskan, maka keluarganya, attorney-nya yang akan memutuskan. Dan kalau tidak ada keluarganya, maka negara yang akan memutuskan berdasarkan pertimbangan dari para multidisiplinari yang merawat pasiennya. Jadi misalnya dokternya mengatakan, ini sudah end of life care, ini sudah ini, kita tidak perlu lagi misalnya cuci darah dan lain-lain ya, seperti di video kemarin yang kalian tonton. Kira-kira begitu Ibu Erni, apakah sudah menjawab? Bu Erni? I think she got the point already.
Terima kasih Bu Bella. Thanks, Muzeyyen.
Ya, thank you Miss Muzi. Saya kira kita waktunya sudah mau habis ya. Apa satu lagi? Ada satu lagi? One more maybe? Oke, raise hand one more from Argalita India. Ya, pertanyaan terakhir silakan.
Okay, thank you for allowing me to ask a question. In the context of palliative care, what evidence-based approaches are most effective in treating case symptoms such as pain, dyspnea, and delirium, especially when patients are approaching the end of life? And how can nurse adapt this approach based on the clinical condition and preference of patient and their families? Thank you, Miss.
Sorry, I didn't quite understand the question.
Yeah. So a lot of questions in the same time, maybe one by one.
I'm sorry, Miss. In the context of palliative care, what evidence-based approaches are most effective in treating key symptoms such as pain, dyspnea, and delirium? Now, especially when patients are approaching the end of life. And how can nurse adapt these approaches based on clinical condition and preferences of patients and their families, Miss?
So
It's a very long topic to discuss because, as I said, today I discussed very briefly the basic information. I think the reason why I suggest to look at the clinical guidelines, what they suggesting about the pain and other symptom management in palliative care and end of life care stages, because you will see in nowadays we have many different management options from non-pharmacological, pharmacological. So it's upcoming many research. So when you see for example, delirium management in a NSA guidelines, there's like almost 3 pages different option that you can provide your patients for managing the delirium based on the non-pharmacological perspective, and then the 1 page is for pharmacological perspective. So it is very difficult to say this is the best evidence for a patient. The reason why, because as I said, every patient are different. We're not expecting the same level of symptom experience, and we are not waiting that every management strategy is working the best way that we're expecting. Like we're thinking the reason why we're having the more than one options for managing symptoms. The reason why I say it, you try one thing, it's not working, resisting the symptom, trying the other things. At this level, I can't say what is the best evidence, because it will be changed based on the underlying causes. It will be changed what is the main reasons, or what is the different factors that affect the symptom experience and end of life care as well. And what is the preference and the values of the patients, what they actually wanted, what they need from their perspective. So this is the reason why I strongly suggest you go through the clinical guidelines to see what is the best one that you thinking it fit with your patient's management. If I say like, for example, pain management, if I know that opioids is the best, I would say the best evidence finds the opioids for pain management, but we won't say that one. The reason why we're providing more than one, and the research showing that in some cases, for example, the cancer pain management, even if the same opioid dose is not working for each patient like we're expecting, because of some other genetic reasons as well. So for me, at least, as a nurse, without knowing what patient actually needs, then saying that this is the best evidence-based online pharmacological symptom management strategies for patients. So the reason why we're telling you the identification of symptoms and the reason what they experience in their symptoms, leading you the most effective and evidence-based practices in the end of life care. I don't know if it answered your question, but this is the case, I will say.
Udah puas, Dian?
Thank you, Miss.
Okay, so she got the point and she is happy with that answer. So I think we already in the end of our international lecture for today. Muzi, please accept our thank you to you. So, and everybody will give their thumb up and clap hands. So this is our certificate for you. And clap hands for Muzi.
Thank you.
Yeah. Okay, so this is the end of our meeting. Thank you very much, Muji, for very clear information and very insightful also. Inspire our students also to do the same research in palliative care. Thank you for having us and hope to see you again.
Hopefully. Thank you very much.
Bye. Okay.
Yeah, say hi to you.
Okay, thank you very much, Ms. Muzeyyen and Seckin. Also, thank you very much for your outstanding moderation for today, Ms. Chandra Isabella.
So, before we conclude this event, we would like to capture this memorable moment. So we want to have the documentation session.
We invite all speakers, moderator, organizing committee members, and distinguished guests to be prepared for our group photograph.
And also for our online participation, please feel free to turn on the camera so we can take the screenshots. And we will also be sharing these photos in our official social media channels shortly after the event.
Yang mana pada ini? Ayo nih, panitia pendaftaran dan lain-lain. Ayo.
Ayo dong.
Oke, sini dong. Biar wajah kalian dipampang di kamera. Bra, kamu bukan panitia, Bra. Kan kamu kasih perlengkapan, Bra. Siti yang judul gitu biar bisa difoto. Ya. Siapa yang screenshot? Ada yang screenshot dari Pangandaran. Oke. Ini minta soal dia abal-abal. Nah, kerja orang-orangnya nggak ternyata. Oke, silakan screenshot 1, 2, 3.
Untuk teman-teman dokumentasi boleh di screenshot.
Oh iya.
Aba-aba udah bilang.
Oke.
Tiga kita aja.
Oke.
Silakan.
2, 3. Wait.
Kayak kameranya ya.
1, 2, 3. 1, 2, 3. 1, 2, 3.
Oke. Okay, as we come to an end of today's international lecture series, we would like to extend our heartfelt thanks to everyone who made this event possible. I would like to say thank you so much to Ms. Muzeyyen Seckin for that incredibly insightful and thought-provoking presentation. The depth of knowledge you've shared with us today is truly invaluable.
That's right, Kansa. So we would like to share our sincere gratitude to Ms. Muzeyyen Seckin and also to our great moderator, Ms. Chandra Isabella, for the expert facilitation, and to the Faculty of Nursing, Universitas Padjadjaran, for organizing this meaningful event.
We hope today's discussion. Oh, I also like to thank for all our participants, both on site and online, for your active engagement and thoughtful question. Your presence and participation have made this event truly felt so special.
And so let us carry forward the knowledge and the inspiration we've gained today as we continue to transform supportive, palliative, and end-of life in care in our communities.
We hope today's discussion has deepened our understanding and renewed your commitment to providing compassionate, dignified care for all patients and families facing serious illness.
So please stay connected with us for future events and opportunities to continue this important conversation.
Once again, thank you all for joining us in celebrating World Hospice and Palliative Care Day 2025.
We wish you all safe travels, continued success in your practice, and the courage to make a difference in the life you touch.
This concludes our program for today. Thank you and goodbye. Wassalamualaikum warahmatullahi wabarakatuh.